Genomic testing is coming and we're using it more frequently in breast cancer. I think one of the misconceptions about genomic testing is that it is a substitute for good clinical decision making. You don't have to just look at the raw test score. You want to integrate still traditional pathology, things like the tumor stage, the size of the cancer, the patient's own preference, the patient's health status. It's not like you look at one number and therefore you run with a decision one way or the other. So these are good tests, they're very helpful tests, but they're not a substitute for still putting together the whole package for the patient and helping them understand where you're at. The value of the Genomic Health Oncotype DX test really is to help the patient and the doctor make a better decision about whether or not to give chemotherapy. So the first thing is, if you know that you're going to give chemotherapy anyway, you don't need the test. If the patient has 15 positive lymph nodes and you're going to give chemotherapy, you don't need to order the test. And similarly, if the patient has a 2mm cancer and you're not going to give chemo, you don't need to order the test. The second thing is that I always frame the discussion for the patient by talking about what the traditional recommendations would be and then how the genomic test might affect our recommendations. So I say things like, historically for estrogen receptor positive node negative cancers, we gave chemotherapy, there was a small benefit. We can use this test to figure out if you're part of the group that gets the benefit or if you're part of the group that doesn't really get the benefit, and I actually show them the curves. And then the other point that's really helpful is that usually we don't have the test result when we begin talking about it. It takes about 2 weeks to get the test result back. So I like to tell the patient ahead of time what number we're looking for a decision one way or the other. So if you say, if the score is 20 or less, we're not going to give chemo. If it's 25 or more, we're definitely gonna. If it's in between, we'll come back and talk some more. But that kind of framing is very helpful ahead of time for letting the patient know what to anticipate.